Welcome, I'm Stephen Bailey, Editor-in-Chief of Catheterization Cardiovascular Intervention, and I'm delighted to be joined today by Dr. Ron Waksman representing his group. He's Director of Cardiovascular Research and Advanced Education at MedStar Heart Institute, and we've asked Ron to discuss the manuscript that was accepted in CCI as an editor's choice, detailing safety and efficacy of everolimus-eluting stent versus paclitaxel stents in diabetic population. Ron, thank you so much for discussing with us this difficult choice of how to choose first versus second generation devices in a diabetic population.
Thank you, Steve, and thanks for the opportunity to be able to present this paper. And I tell you what was driving this whole research effort. We all know that diabetic is still a subset which we're struggling in terms of intervention. Most of the studies showing that bypass surgery is doing better when we're coming to multivessel disease. And we're trying to find what would be the best DES for the diabetic population. And if you recall, when we had the first generation Cypher and Taxus, there was more discussion that maybe there is a favor of the PES over the SES because of some mechanism that would not be related to the mTOR with the paclitaxel. But that was all a hypothesis, and it was never clearly translated to clinical benefit in terms of the randomized clinical trials. Nevertheless, there was a notion, and there was some publication that did favor PES over SES when these were two first-generation DES. Now that we have the everolimus-eluting stent, which is the second-generation DES, we actually wanted to look more specifically into this question, knowing that from SPIRIT 4 and also from Compare, if you look at the entire population, EES was better than PES. But we wanted to go specifically on the diabetic patients and to look at what was called at that time the best DES from first generation vis-a-vis PES against EES for the diabetic population. So that was the motivation to go into this investigation.
Well, I think that you worked very hard with your group, accumulating nearly 1,000 patients. That's a difficult database to have. And I think that you had some important conclusions regarding the safety outcomes.
True. And again, this is all comers. So it's a contemporary practice that we include everyone into the database. And when we looked into the two groups, we did found that the EES were superior in terms of the safety aspects when they compared to the PES for this population. And most striking was the stent thrombosis aspect, because we have seen actually 0 stent thrombosis in the ES group versus 1.9% in the PES group. Now for the 1.9%, it's pretty much what we have been seeing. This is within the 1 year. This is what we have been seeing with the PES in the literature in terms of stent thrombosis. But the fact that we had the 0 ES, it may be a luck. Maybe we were lucky, but still it suggests that there is a very low rate of stent thrombosis in the diabetic patients with the EES group. And I think it is important because we know that diabetic patients tend to have a little bit more stent thrombosis than the regular population. And I would assume that we're doing everything under optimization. As you know, in our lab, 60 to 70% of the patients are IVUS guided. So that's actually raised questions again, and to another hypothesis that was alluded in the past, which regards to the EES DES, which reflect to the polymer. And there was some who suggested that the fluorocopolymer, which is on the EES system, has some thromboresistant aspects or features, which could explain those features. But I would be cautious about it because most of the stent thrombosis on the PES were within the first 30 days, which could be driving from a different mechanism of optimal deployments, et cetera, et cetera. So that has to be still looked into more carefully about the features of the fluorocopolymer as a thromboresistant. But that's probably true across the board if you look on studies with EES. This is also translated to reduction in target lesion revascularization and also reduction in death. So I think that it is provocative. It is suggesting that even for the DES, for the diabetic patients, when you have to choose a DES, EES is superior to the PES.
Well, I think these are great observations, and as you said, the stenting that was done really was done in a way that is perhaps even more rigorous in other centers, with a high percentage having IVUS to make sure you had adequate deployment. So some of the issues that are brought up in other studies seem to not be present in yours. The whole questions that you bring up, I think, about timing when there are adverse events between the devices is important. I think also it's going to not be answered by your study, but perhaps one of the other questions that will be provoked is timing of dual antiplatelet therapy. I know that that really wasn't an endpoint that you had, but perhaps you might provide us your thoughts about DAP therapy and whether it's in diabetic patients going to differ.
Yeah, so I think you touch on a very delicate point. As we know, diabetic patients also has more high on platelet reactivity, which means they have more resistance to Plavix therapy. And I think those patients probably should be preferable treated with second generation antiplatelet therapy, because that's the reason why they are more prone to stent thrombosis. So again, we do have to recognize that diabetic patients are more complicated. And I would advocate that those patients should be treated with second generation DAPT. But what we actually hope that this paper will provoke others to continue to explore ways to develop better features for DES for diabetic populations, so we can go back into the arena and not just give up everything to revascularization by surgery. And by optimizing DES and antiplatelet therapy, we can at least even our results with CABG right now for the more complex diabetic patients.
Well, thank you so much. I think you've given us a lot to think about. Hopefully that will have bearing on some of these important questions to follow, particularly in comparisons between drug-eluting stents and surgical revascularization. And we are grateful that you were able to spend some time with us. Thanks again, Ron.
Thank you for the opportunity.